welcome to those of you online, and great to see people here. I would like to begin by acknowledging that I have no conflicts of interest except for my undying love of my miniature dachshund Schnurp. I also would like to thank the really awesome colleagues, students, and staff at the various places I work or advise for or do something for. They're great, and I'm lucky to have an amazing community of people around me. I'd also like to thank my family. Really, all of the work I do in one way or another comes out of experiences that I had with them, those who are still around, and I'm very, very grateful that I was lucky enough to be born into such an amazing and a loving family. I'd like to begin today's talk with an epigraph. This comes from J.J. Gibson. For those of you who are big fans of ecological psychology, you know who he is. It was a big hit back in the day. I'm not sure how popular it is today. Nonetheless, I digress. The quote I'd like to begin with runs as follows. The meaning or the value of a thing consists of what it affords. I want to begin with two stories, two anecdotes, if you will. The first one was near the beginning of the COVID-19 pandemic, which of course we still have with us. We just treat it as an endemic now. Yay. In December of 2020, National Public Radio correspondent, this is the main national news, both radio station, they have a video component that no one watches in the United States. Investigative reporter Joseph Shapiro detailed the story of a woman with intellectual disabilities who sought medical care at, this was the start of the COVID-19 pandemic, and it was in a small rural town in Pendleton, Oregon. That's in the Pacific Northwest, and it's actually a place I know because I have extended family members who live there. I myself am from Eugene, Oregon. She needed a ventilator, but her physician denied it, citing her quote-unquote low quality of life. He asked her to sign a form that would allow the hospital to deny her further care. After threats of lawsuits, this woman was transferred to another hospital. She was given the treatment she needed, and she ended up being just fine. Now, Oregon Senator Sarah Gelzer, also seen here on the PowerPoint, she told NPR, and I quote, "Nothing happened to that hospital. Nothing happened to the physician. The health authority confirmed that it had, in fact, been a coerced do not intubate order. They confirmed it happened. There was absolutely no sanction." And reporter Shapiro, he added, the state records that NPR was able to obtain showed that other people with disabilities were denied coronavirus tests, coronavirus treatment when they showed up at the hospital with symptoms. And just to be clear, if you think, well, it's the US, you know, the healthcare system there is a hot pile of fill in the blank. Surely this couldn't have been happening around the world. I'd just like to remind you that it was happening so much around the world that the United Nations had to quickly put together guidance documents, essentially a reminder of all the signatories, of the 181 signatories to the UN CRPD, the Convention on the Rights of Persons with Disabilities. I think this came out in early April, like, hey, you don't get to deny care on the basis of disability, by the way. Second story or anecdote. This one comes from the context of pediatric care. In 2016, John Lantos, many of you will know him as both a practicing pediatrician and a bioethicist, he published an editorial in JAMA, the Journal of the American Medical Association, and it was entitled Trisomy 13 and 18, Treatment Decisions in a Stable Gray Zone. Now, it's normally bad form in a presentation to read a long quote. I'm going to break that rule because it's important to capture the kind of exact phrasing of Lantos's argument. He writes, 30 years ago, oh, I forgot, I have a picture of him, there he is. He writes, 30 years ago, pediatric residents were taught that trisomy 13 and 18, right, also known as Edwards and Patau syndrome, these were just lethal congenital anomalies. Parents were told that these conditions were flatly incompatible with life. And accordingly, there was a tacit consensus that life-sustaining treatment was not medically indicated. and clinical experience was exactly as you'd expect. It was consistent with this self-fulfilling prophecy. Occasionally, though, some infants with these conditions, they did survive. The children were, in almost every case, institutionalized. They were described as severely impaired, and these case reports were treated as the rare exceptions that more or less proved the rule. In the age of social media, however, everything changed. Parents would share their stories and videos, whether on Facebook, Instagram, TikTok, you name it, showing their happy 4- and 5-year-old children with these conditions. Survival, it turned out, was not as rare as once thought. And children who were not institutionalized, that is a very, very key component of this story, those who were not institutionalized, they looked happy, they looked cared for, they looked loved with their families. And it became increasingly awkward to describe these conditions as incompatible to life to parents who had evidence right at their fingertips seeming to suggest otherwise. Still, old myths die hard. Some die very hard. Many physicians still today, still in 2023, tell parents that death is simply inevitable for these aneuploidies. Former United States Senator Rick Santorum, you might remember him, but if you don't, just don't Google his last name. Senator Rick Santorum, he's spoken about the counseling that he and his wife received about their daughter Bella. She had trisomy 13. After she had spent 10 days in the NICU, Bella's condition was stable with supplemental oxygen. The physicians agreed that Bella would go home and she'd receive hospice care. The parents said, no, we want her to continue getting oxygen. The physicians wanted to discontinue it, and one of the physicians bluntly told the Santorums, this is what they report, they were told directly to their face, you realize that your child is going to die, you have to let go. They got the oxygen. The parents won this particular battle. Bella survived. A few months later, she had a viral upper respiratory tract infection. It did lead to respiratory arrest. Her parents provided cardiopulmonary resuscitation. Again, she survived. She, at the time of this 2016 JAMA piece coming out, she was 8 years old. Far as I could tell, I'm not the greatest internet sleuth, but far as I could tell, she is still alive today. 2016, 7, I can do math, so she's 13, she's however old that is, 14, 15, something. Numbers are hard. I work with words. There's a lot that can be taken from, there's a lot to think about in these two very harrowing anecdotes and stories. And here's what I want to focus on today. There's actually 2 points, but the first one is really the heart of today's talk. First point, there just is, point of fact, a fraught relationship between disability and assumptions concerning quality of life. And this fraught relationship across the interactions that practitioners have, whatever their clinical specialty, it plays out across the way in which hospitals think about the care that they provide, it plays out at the level of insurance, it plays out in all sorts of ways. And second, and again, I'm not going to focus on this, but this will just kind of hover in the background. There's a large society-wide failure. My examples are going to come from the US, but I think mutatis mutandis, this may apply to many other nation states. A large society-wide failure to provide the necessary conditions for not simply equal care, but equitable care. Now, on this first point, you might say, okay, Joel, stories are cool, anecdotes are cool. That's I want data. Give me some hard numbers. Give me some evidence that goes beyond some reporter reporting something. So let's do that. In February of 2021, in the journal Health Affairs, Lisa Iazzoni and a team of hers based out of Harvard Med, I think there were people at other institutions, but that's where at least Lisa is. She published this piece that looked at 714 practicing physicians. Again, this is coming from the US, so my apologies for not having the same sort of study in New Zealand. My apologies. I'll get on that very soon. This study had a number of, let's go with worrying findings. For example, they found out that only 40.7% of these 714 physicians express confidence in their own ability to provide the same quality of care to their disabled patients as they do to their able-bodied patients. Only 40% felt confident that they could do that. Another finding that was worrisome was that 82.7% of them, when they were asked, do people with significant disabilities have a good quality of life, low quality, what do they have? 82.4% said people with significant disabilities have a low quality of life. Now, here's why that finding is a problem. We have over 30 years of social scientific evidence looking at the relationship between people with disabilities and quality of life / life satisfaction / fill in whatever your preferred metric is. The finding that people with disabilities report similar levels of quality of life to able-bodied people is so famous in the literature, it's had its own nickname since the 90s. It's been referred to, it was kind of canonized as a unusual finding in the 90s by Albrecht and Devalue. They called it the disability paradox, and here is how they described this unusual finding. They said, well, look, common understanding of a good quality of life, that implies being in good health, it implies experiencing subjective well-being, life satisfaction, duh. Conversely, one could argue that if people have disabilities, they simply can't be considered to be in good health or possess a high level of life satisfaction. People with disabilities are assumed, keyword they're assumed, to be limited in function and role performance and quite possibly stigmatized and underprivileged. You don't need the quite possibly qualifier there. There was plenty of evidence in 1999 that definitely there are systemic issues of stigmatization, discrimination, and oppression of people with disabilities. I digress. They continue. Research evidence, however, presents a more complex picture. In practice, the anomaly, the unusual finding, is that patients' perceptions of personal health, well-being, and life satisfaction are often discordant with their objective health status and their disability status. Now, of course, you might notice it's not properly a paradox. This is just an unusual finding, an anomaly, but it's been called the disability paradox. You might say, okay, well, a study of 714, it's just physicians in the US, that's good. I want more numbers. I want a different data set. I want a bigger data set. Give me something that demonstrates that this is really the case. Oh, I forgot about that slide. I'll come back to that in a second. So here's a study of 25,000 clinicians. This was one of these studies that's based off of people taking one of those implicit bias tests. This study found that despite a majority of clinicians reporting self-awareness of ableism, that's great, and also reporting that they themselves are not biased against people with disabilities, that's great. Nevertheless, the majority demonstrated implicit bias against people with disabilities. And the way that the people who did this study, the term they used was that most physicians demonstrated themselves to be what they called aversive ableists, right? So low explicit prejudice, high implicit prejudice. I'm going to go back to the slide that I skipped over, which was my "it's more complex than it seems" slide. When I say it's more complex than it seems, go back to my claim that the idea that people with significant disabilities, they don't necessarily have a lower quality of life. That is true at that level of generalization, but once we get into subpopulations and particular types of disabilities, now we do have a way more complex picture. If you have depression and anxiety, whether it's your primary disability or something on top of it, that will absolutely pull down quality of life and life satisfaction. Acquired disabilities will often pull things down, especially in the initial years after it's acquired. So I just want to be very clear, it's actually quite complicated. And speaking of the Journal of Philosophy of Disability that Dr. Johnson mentioned earlier, a piece just came out in our newest issue, a philosopher looking at the empirical data and then doing a kind of critical analysis of how it bears out for these larger claims about how being disabled in general relates to quality of life. It's a really, really great piece. It's an open access journal. You can go read it if you want to get more into the weeds of how complicated the these data actually are. So, here's what I would like to focus on. It is very easy to hear this sort of information and think, okay, I get it, Joel, there's biases at issue here. Everyone has biases, maybe let's just focus on biases. Or that's the issue, is focusing on biases. Okay, how do we do that? I want to be very clear about 2 points. One, I don't think this is just about bias. As I'm going to make clear in a moment, I think this is equally, if not more so, about concepts. And I think that how we conceptualize disability fundamentally gets in the way of / is motivating some of the things we're seeing come out as biases against people with disabilities. And I'm going to try and unpack that and think through what that means at a number of different levels. I also want to make clear that the reason talking about biases, and for that matter, talking about how we conceptualize various groups of patients or subgroups of patients, whatnot, part of the reason this matters has to do with not simply how we think, but how we communicate, right? So we've got a very robust body of evidence suggesting that patient-practitioner communication itself plays a key role in determining health outcomes. That's kind of a wild finding. From a certain angle, it's just wild that how you talk with a patient could itself be a factor in determining their health outcomes, but that is what these data seem to suggest. And what that means in practice, to be more clear, is that effective communication, right, where patients report high satisfaction with how they've communicated with whatever the clinician is doing or may be, high patient satisfaction leads to better outcomes, and conversely, poor communication, so where patients are reporting low satisfaction, that can harm patients, and here's the real kicker, it increases the likelihood of medical error. So it's not just an issue, this is not just important if we want to improve health outcomes, it's also important if we don't want to get sued and we want to avoid medical error. So the stakes here are actually quite high and quite central to the delivery of good care. Oh yeah, I forgot I had this bullet point. Like when I say it can lead to medical error, this is not like a tiny issue. According to some studies, improper diagnosis and treatment, of which I'm suggesting communication is only a component of a reason, but we're talking tens of thousands of deaths each year, right? So this is a very significant thing. Also a plug for a paper I wrote with a dear friend and also colleague of mine, David Pena-Guzman, while he was out at the Berman Institute at Hopkins. If you want to think more deeply and have some more kind of materials and meat about these issues, this paper that came out in the Kennedy Institute of Ethics Journal, we try and do a deep dive of what the relationship might be between thinking about disability, between epistemic injustices, situations where patients with disabilities are not necessarily treated justly as knowers, and medical error. That paper, I won't say it's written kind of mostly to philosophers, but I think it's still okay to read, so my apologies if it's not like super fun to read. Okay, so I made that general comment about the role of patient-provider communication. I want to add a further data point, which is that disabled patients' reporting of satisfaction with their practitioners is quite low communicatively. So here's a study from 2009. This was based on a particular survey that I won't go into that relates to the US healthcare system. But Smith reported that those with a disability are significantly more likely than those without to perceive that a physician does not listen to them, does not explain treatment so that they understand, does not treat them with respect, does not spend enough time with them, does not involve them in treatment decisions. So this is a big issue if we're worried about providing equitable quality of care to disabled patients. This is a big one. Well, what's the underlying cause? One possible solution, and this is what's going to bring us to the conceptual part, is that ableism is getting in the way. Ableism is specifically, oops, I'm missing a bullet point there. What it's supposed to say after this is that ableism is leading us to have deficient or not sufficiently nuanced enough concepts regarding disability, and it's leading people to think incorrectly about what the relationship is, what the actual matter-of-fact relationship is between various disabled patient populations' lives, their quality of life, and the reasons that they are actually in front of the clinician in any given case. Well, you might say, okay, but what, Joel, is ableism? If you ask two researchers in disability studies or philosophy of disability what ableism is, you will get two slightly different answers. But you know what? That's okay, because when we're talking about social phenomenon, things are going to be fuzzy, and that's just the way it is. Having said that, for the purposes of today, I'll throw out a definition that we can at least work with, and it goes like this. Ableism is the assumption that the standard or normal, that of course has to be in quotation marks, normal relative to what? Normal in a statistical sense, normal in a evolutionary biology, like, you know, so that has to be in quotation marks. The assumption that the standard or normal able body is in and of itself better than non-standard or abnormal forms. And because I don't want you to think that ableism is just an assumption, I'm building in here the idea that it's also the discrimination and oppression that leads from, or excuse me, that results from that assumption. You might think about that for a second and go, okay, so ableism comes down more or less to what people are thinking. It's very cognitivist. Assumptions are cognitive phenomena like beliefs or judgments. And this has led some people to distinguish, as I will do again today, at least for the purposes at hand, between ableism and structural ableism. Structural ableism would be something like the systems, the practices, the institutions, the habits that assume able-bodiedness as the norm, and then by virtue of that assumption result in the active exclusion and stigmatization, of disabled people. I think the very best definition of ableism would probably combine all of this. You wouldn't actually need to split this into two, but I'm just doing it to kind of motivate you thinking about the ways in which ableism is not simply in people's heads, but is also out in the world, and also is a relationship between the world and how people think. One of the problems with ableism, and those who happened to make the talk yesterday will have heard me talk about this at much more length. One of the problems that ableism leads us to is that it leads us to think that disability is experienced monolithically, that disability just is one thing, disability is negative, right? And for shorthand, I refer to this as the ableist conflation, right? The conflation of experiences of disability with experiences of pain and suffering. And this is a very, very big mistake. I think this is at the root of many different sorts of conceptual mistakes people might make about disability. I think this is also at the root of a lot of the biases that people have against disabled people. And I'll explain why the conflating of experiences of disability with negativity is so wrong in just a second. So to turn things around, let's start with research and philosophy of disability. I'm going to draw here on Elizabeth Barnes's fantastic 2016 book, The Minority Body, where she makes the claim and she defends it across the book. So if what I'm about to say makes no sense to you, you can read the book and then you get the whole argument. She argues that there's nothing about what disabled bodies are like that by itself unifies or explains disability. What in the world does that actually mean concretely? If you were raised the way I was, you might have heard about people who are deaf and thought, oh, deafness, that means you can't hear. Right? Deafness, by definition, is audiological loss. If you actually talk with people who are deaf, especially many people who are born deaf, you'll find that that is fundamentally not how they experience deafness. They experience deafness instead as the ability to communicate with others who share their language, ASL, BSL, whatever it might be. Not only is deafness, on that understanding of deafness, not only is it not a deficit, not only is it not something that comes along with pain, suffering, disadvantage, or whatever, it is quite literally a gain in the same way that being fluent in some extra language is obviously a gain going through the world. Let's take a different example. You might say, okay, I see the point with deafness, or for at least some people who are deaf and understand deafness that way. What about, I don't know, blindness? Surely, Joel, you're not going to sit there and tell me that being blind doesn't mean you can't see. Well, if you actually talk with people who are blind, not all, but many will talk about the way that they see. They don't see in the exact same way I do with these two weird gelatinous jello globes in my head, but they do absolutely see. One great example of this is sociologist and really poet, he's an unbelievably beautiful writer, Rod Machalko. I have an image there of a famous book of his called The 2-in-1, where he describes what it is like to see going through the world with his dog, Smokey, and what it's like to navigate the environment quite literally, well, not literally, seeing but in a different way. Or let's push it a little farther. How many of you have heard of Daniel Kish? So Daniel Kish was born blind, or he might have become blind very, very early on, like 2 or 3. I can't remember now off the top of my head. He can do everything I do in an average day. He can ride a bike. He can, I don't know, whatever. What have I been doing today? I've mostly been sitting. He can definitely do that. But he gets around the world by echolocating. Right? He makes clicks and also taps with his feet and whatnot. And just in, we all know what sonar is, right? I assume. He can quite literally map the environment around him using echolocation and can navigate on his own. This is, granted, there's not a lot of cases of this with people who are not congenitally or it happened, right early on. Part of that has to do with plasticity, part of the brain, there's lots of reasons for that. But it's really weird to say he can't see in some sense, right? He's just using a different method to map the environment around him than I happen to be using. And side note, very, very important side note, you might say, Joel, that's really interesting that there's a few people who can do that, but it's not a high percentage of people who are congenitally blind, so there. Do you know why? The research on this, it has an answer to why more blind people don't echolocate. They are almost always stopped from making the sounds necessary to develop the skill. Stopped by their parents, stopped by their teachers, stopped by people around them who find the clicking annoying. It is a social reason why more blind people don't echolocate. It's not some, it's really, You're like, okay, Joel, you've been focusing on main sensory modalities. I'll grant you the deafness point, and maybe I'll grant you the point about blindness, but don't look me in the eyes and tell me that someone who happens to not have stuff underneath both of their knees, that's not a lack or a deficit. Surely that's just purely, something is missing there, something is wrong. Well, you might recognize this image, if people know who this is. Oscar Pistorius, world-famous sprinter. And then he killed his girlfriend, and then became known for murder. So that's unfortunate. It's don't murder. That's bad. Really ruined his story. Anyway, I digress. So he was extremely fast, like wildly, wildly fast. And the ICC, whatever that, the top international body of the Olympics, they had to make a judgment. I can't remember what actually precipitated this, but they had to make a judgment on whether or not he could compete in the regular Olympics. And they said, no, he can't. But do you want to know why they said he can't? They figured out, had an advantage over people with bio-legs. These cheetah blades, brilliantly designed, by the way, because this thing, evolution did a horrible job with our legs. Anyway, these brilliantly designed cheetah blades, they figured out, had a significantly lower metabolic cost. And so they're like, you can't run with the normal people because you have a super ability through these prosthetics. And my point here is, obviously, it's simple, but it's really important. Through the interaction with technology, in this case, in some sense, a purely, more or less biomedical tech, something that appears to be clearly a deficit, a lack, something negative, can not only become neutral in the sense of certain things that someone wants to do can be done just as well in a different way, they can actually take someone to the point of having an advantage over people who aren't using that tech. And there's a whole ton of work in disability studies about how engagement with forms of technology can just fundamentally modulate what a disability's meaning is in really, really fascinating ways. You might say, okay, Joel, you're only focusing on kind of more or less physical stuff. You know, we also have brains. There's also things like behavior, cognition. What about that? If you have been paying attention at all, I hope, over the last 5 to 10 years, the neurodiversity movement has become a really, really kind of strong force in multiple places around the world. And there are many people who identify as neurodiverse who will say, look, yes, I process things differently than your typical person. Yes, I behave maybe differently than your typical person. These are not deficits. These are not problems. The problem is a world that is trying to box me in to act like the quote-unquote normies. I am just different. This will be especially true of some people who are autistic. Some people will talk about various things like ADHD in this way. I want to be very clear, this is not true of everyone. There are all sorts of let's say, of the range of different cognitive differences or even cognitive disabilities, not all are described in this way as merely being differences, but the general thrust to say there are at least some forms of this, that the problem is the environment. The problem is whether or not someone is afforded to go through the world. That is the actual issue. It's not a deficit, a lack, something negative, problematic. And this is a bit of a left turn. I'm not sticking with the trajectory of the last 4 things, but I do want to mention this because I think it's absolutely crucial. One of the reasons historically ableism has been so thoroughgoing throughout cultures, and not just in the West for that matter, is because of a lack of disability representation. Whether, and I'm talking representation in every sense of the term, whether through arts, whether through media, whether in politics, whether pick your domain, that is not a necessity of the way the world works. A lot of that is choices and people with disabilities being actively excluded. And in the last, I'd say, 8 to maybe 12 years, one very positive thing I can point to is that disability representation has started to get better at the level of media. Think of Peter Dinklage in Game of Thrones. Think of Niall DeMarco, who won America's Next Top Model and is proudly deaf. Think of Ali Stroker, who is the first person who uses a wheelchair to win a Tony. Think of Haben Girma, the first deaf-blind person to get a JD from Harvard Law. These stories of people with disabilities actually living their lives, doing all sorts of things, are finally getting a bit more airtime, and the actual rich complexity of disabled life is getting more eyes on it, let's say. A lot of this honestly has to do with like social media. Like my students, my Gen Z students, the TikTok generation or whatever they're on now. I don't know what they're on now. I'm behind the times. But they, you know, like disability TikTok is its whole thing. And they're getting direct kind of information on what things are like, not necessarily being filtered through some sort of ableist prism. And this is, I think, a really, really good thing. There's a long, long way to go, but there is at least a glimmer of hope here. All right, coming in the home stretch. I'm going to go a bit quickly over this point, partially because I'm hoping a number of you in the audience will already know about this stuff, but I still think it's worth repeating just in case there's some who don't. The issue of ableism, there's lots of different ways to try and address it. One way it has been addressed is through the history of disability activism, right? And disability activists who for a long time have been saying, hey, a lot of the problems we're experiencing, maybe most of them, is about a world, an inaccessible environment. They came up with a very powerful, simple heuristic to try and make this clear to people what they mean when they talk about there being stigmatization, discrimination, oppression against them. And here's how it goes. Activists will distinguish between the medical model of disability, right, which is what probably most of you were taught as a kid, right? Disability means something is wrong with someone's body. We don't know exactly why necessarily, but poor you, something's wrong with you. They will contrast that with the social model, where disability names the negative effects caused by society to people's impairments. Now, I introduced a new term there. What is an impairment? On a social model of disability, an impairment is someone's atypicality, the way in which they're, you can even say, abnormal. But disability refers to the response to that impairment. What does, I'm going to skip that slide. What does that actually mean? On a medical model of disability, you look at this image, and it's very obvious what's happening, right? Something is wrong with this individual. Something is wrong with their body or their mind. Maybe they're paraplegic, there's an issue with their spine. Maybe they have really severe lethargy from fibromyalgia this day. Like, we don't know what it is, but something is wrong with them. And the thing that's wrong with them is keeping them from using the stairs. That's a medical model definition. Also, asterisks here. Obviously, there is no unified medical model of disability, right? There's actually really complex models of disability across different subspecialties. Rehabilitation medicine has a very complex understanding of disability and has since the late 60s. I'm repeating a way of thinking about things that activists have used to get things done in the real political world. So just be generous with how these terms are, in some ways, a little bit too general. That's a medical model. What do you see on a social model? You see something very different. Whatever the impairments that this person has, right, there is something atypical, at least in the sense that it is not statistically normal for everyone to use a wheelchair. Whatever impairments this person has, they have run into a situation where people chose to make it so that if you cannot ambulate, you cannot get from point A to point B over an incline here. And this is a lot of concrete. There were multiple people involved in this decision, actively choosing to use stairs as opposed to ramps, as opposed to whatever else could have been done here. What you see, in other words, on a social model is a social decision to exclude certain people from this built space. And the point, of course, the point is not that one or that either of these models is the only right way to think about it. This is a both and, right? As a regular joke goes in disability studies, scholar communities, and also in certain disability communities more generally, if you go into the ER, you sure as hell hope they're using a medical model of disability. They better be, or you're going to pick a different emergency room. This is about both and. So, what does this mean? This means, among other things, that the problem, the reason there is this mismatch between how clinicians think about the relationship between disability and quality of life, part of the problem is not appreciating the rich complexity of disability and not appreciating the way in which disability is not reducible to, is not simply a question of how someone's body or mind is, but of how their body and mind interacts with their environment. And I'm putting this up here, not because I'm promoting, I did co-edit this book, but the reason I'm putting it up here, I wrote almost nothing inside the book. It's 38 chapters by some absolutely phenomenal scholars taking core issues in bioethics. Everything from physician aid in dying to genetic engineering to you name it, and thinking about these issues by centering the actual testimony of disabled people, by centering research in disability studies and philosophy of disability. And lo and behold, doing that, you get some different sorts of conversations around these issues. And I'm really, really proud of the work that was done by the scholars in this book. And I put it up there also because if you're like, okay, well, can you explain more concretely how this would apply to how I think about whatever, some specific particular issue within a subspecialty, the fullest answer is going to come from this book as opposed to anything off the top of my head. If we want to build an anti-ableist infrastructure in healthcare, and I want to be very clear that I think addressing ableism is not enough, right? And there's an analogy here between how people working on issues of racial justice will talk. They'll say, like, knowing that racism is a problem and trying to address racism is not enough. We need to be anti-racist. We need to actively fight against racism. If we want to build an anti-ableist infrastructure in healthcare, and if we want to achieve equity in care for disabled patients, I think among other things, it will absolutely require that we think in a more complex way about disability. That we not just acknowledge ableism, right, as an issue, and not just attempt through, metacognition to address our biases against disabled people, but to really kind of re-engineer how we think about what disability is in the very first place. Now I promised, or I think I promised, that I'd make this even more concrete, right? If you're a clinician and you're like, okay, this is all very interesting, but what do I do differently when I am actually sitting in front of a patient who is disabled? So I had the great joy of writing this short piece for the American Medical Association Journal of Ethics called 3 Things Clinicians Should Know About Disability. And it seems to have been useful, at least that's what people tell me. And I tried very hard to take some of this larger conceptual analysis, disability studies, history stuff, and say, okay, well, what are the takeaway points and what can I do differently? And then they didn't tell me this was going to happen, but I was delighted that they chose to make the article into this graphic. I did not do this. This was Jessica Carpini, who reinterpreted what I had written, like turned it into bullet points in this nice graphic. It's always weird to see someone like synthesize what you've done. Like, is that what I said? So I love it, but I'm gonna I'll also add a few little notes here. Here's what she thought I said in this piece. The big takeaways to learn are that everyone will someday be a person with disabilities. I didn't actually say that yet today, but that's a great point. If you want to live a long life, that comes along with disabilities and impairments. So if you want to live a long life, you are perforce saying you want to have disability be a component of that life. There's just no way around that, no matter what the anti-aging people, no matter what they're trying to sell us. Second, people with disabilities flourish, and you can contribute to their flourishing. Third, plurality in embodied human form is normal, not abnormal. Whether it's sensory modalities, whether it's behavior, whether it's things regarding cognition writ large, we are not all the same. And there's nothing wrong with that. And there are all sorts of ways to flourish with differences from the quote-unquote norm. I thought those were pretty good summaries of what I think I said in that piece. And here's the big takeaway. Here's what can you actually do differently when a patient is in front of you. First is, when thinking about what disability means and when interacting with a disabled patient, fuse clinical understandings, quote-unquote medical model understandings of what disability is, with that patient's lived experience. And often, the best entry point for this is by not assuming you know what that person's disability means for them, and instead asking them about it. Asking them what it means to be disabled for them, asking them what they actually feel is the primary issue that brings them into the clinic that day. It is a mainstay of reports from people with disabilities that they will get into a clinical situation and the clinician will think that the problem is something related to their visible disability, when the reason they're in there has nothing to do with that, or the reason they're in there is related to it, but it's a secondary phenomenon, it's epiphenomenal to whatever their disability is. So much can be done just by trying to be open about, well, maybe they're understanding, maybe they're proud of the way in which they're disabled, and also maybe the reason they're in here has literally nothing to do with their disability identity, or just their visible disability in that sort of a case. Second, share authority in communication and decision-making. I mean, I'm really just here, I guess, the summary of what I was saying is engaging with all the literature on shared decision-making more generally, but I think approaching decisions about care with disabled patients, bringing them into it and asking for their thoughts and assessments is especially important. And then third, elevate patients as experts in living with disabilities. And this might feel like a little bit of a repetition, but it's, I think, worth it. There is this thing able-bodied people do, where they see someone with a disability and they go, oh, I bet I know what that's like. I just minus whatever I have. I minus it from my experience and now I know what it's like. Oh, you're blind. well, if I close my eyes and walk around, oh, so that's what blindness is like, it must suck. Oh, you're whatever, fill in the blank, and then you minus it. That's just not how things work. Like imagine someone who is Jewish and devoutly Jewish, and they're learning about Buddhism, and they're like, oh, well, I know what it's like to be Buddhist. You replace this holy text with some other ones. You replace this particular practice with this other ones. You change out the synagogue for whatever. Like, in the same way that's absurd. Because religions are world creating. They are full. They completely shape and suffuse one's experience. In the same way, it would be really weird for someone to think that about how religions are different. Disabilities do that too. And so you can't just imagine, I think it's almost always an error to imagine that one can know what it's like to be disabled by simply trying to adjust one's able-bodied experience. It's actually not all of the references, but it is some of them. Thank you. You get to throw this, apparently. I'm very excited about that. Just put your hand up.
So our first online question is, objectivists about well-being, for example, objectivist theorists, may maintain that some disabilities reduce the capacity for well-being, even if those people feel as though they have a better life than the objective measure. Is this an argument that is made by objectivists, and how would you respond to this?
Yeah, great question. So I'll just start by saying that I'm deeply skeptical of objectivist accounts of well-being. The only part I can get on board with is like very, very minimal threshold sort of accounts. And I usually would like those to be as minimal as possible. So aside from that more general comment about my suspicions, how do I want to phrase this? If an objectivist about well-being wants to claim that there is some condition that necessarily pulls down well-being, my first response would be, show me the social scientific data. And then I would want to dig into their sample size. I would want to dig into how they set up the questionnaire, if that's the method they're using. I would want to really dig into the extent to which they can be confident that the reports regarding life satisfaction are tracking the condition in and of itself, as opposed to the way that condition interacts with a world that in many ways we can change. I'm looking at you like you asked the question, so sorry about that. I need to look at the camera because that's for the hello person in the interwebs. You know, I would want to put on a very serious social scientific hat and not just a philosophical, theoretical hat. And part of the reason I would want to do that is a lot of the objectivist literature, I think, doesn't do that, and they just get things fundamentally wrong, or they end up making claims that are not actually tracking people's lived experience very well. Yeah. Main point, I'm just deeply skeptical. Well-being is so fundamentally subjective. I'm really suspicious about objectivist accounts. Very suspicious.
Thanks. And thank you very much for your presentation. It's really, really interesting. This is going to be a bit convoluted because I haven't really had a chance to formulate it properly.
I love convoluted questions.
Good. Well, let me start. So this is about the idea of a standard or normal is better than non-standard or an abnormal form. And I wondered whether, I was envisaging a very busy clinical space where the doctor or whoever it might be is dealing with a great deal of patients on a quick basis, and where one of the purposes of medicine is clearly to relieve suffering and restore function. That's a kind of sort of underlying mechanism and an important sort of concept for medicine. And I do wonder whether that is how we get to the situation where we've got that thought that standard or normal is better than non-standard, and how we might respond to that, and particularly the challenge for medical education in responding to that. So it's a very convoluted, sorry about that, just trying to get it in my head right. So
Yeah.
have you looked at medical education or ways in which that we might combat this idea of ableism?
Yeah, so I'm happy to report I've gotten to work with Liz Bowen, who is at the Hastings Center and now is at, I think, that's Mercer Gary. Liz Bowen is at University of Albany or SUNY School of Med, anyway, somewhere in New York working in med school, and Liz is right now trying to figure out the answer to your question, working on how can we make the medical education curriculum have it not simply think more capaciously about disability, but be anti-ableist in the way that we would want a medical education to be anti-racist as well. So I don't have the answers, but Liz, you can find her email, would definitely have a good answer to that. For your earlier, or the kind of the earlier point about how, you know, what are the primary goals, the fundamental internal goals of medicine? Yeah, you said increase flourishing and what did you say?
No, I said reduce pain and relieve pain and suffering and restore function. That's, you know, kind of.
Yeah.
And yeah.
So one thing I would say, two things I'll say. Identifying the root causes of pain and suffering is far more complicated than most people give it credit for. And the structure, the way in which we have structured healthcare systems in modern societies, often we have already narrowed the possibilities of how we can address the root causes before the patient even shows up in the clinic. Or a different way to phrase it is, as the mountain of research from social epidemiology tells us, your genome is not the best predictor of your health. Where you live is. Or in the US, you can say it even snazzier, your zip code is the best predictor of your actual health. So I do worry that there's kind of a chicken and egg here thing in terms of actually addressing pain and suffering. Regarding the restoring function, I'll just give a plug to a fantastic paper by Joseph Strimondo. Came out, I want to say 2 or 3 years ago. And he says, in many cases, restoring function is the wrong aim insofar as it builds in a problematic conception of normal, and the goal should be replacing function. Because there's so many ways that there's so many situations in which you don't need some ideal, and you certainly don't need a normal body as your reference point. What you need is the person to be able to do whatever they need to do, and that could be in all sorts of different ways that have nothing to do with the norm. And so I love this idea that it's not so much restoring, but replacing, and also just having a kind of more capacious notion of like, there's lots of ways to achieve ends. Yeah.
Yeah, that sounds great. Thank you.
What progress would you like to see in medical education for doctors treating people with disabilities, and should there be more disability representation in clinical care?
Yeah, I'll just add one thing, which is there's simply, like, there is not a representative number of disabled physicians, disabled obstetricians, disabled nephrologists. Like, there's not a representative number because the barriers around access to becoming a doctor, becoming a nurse, becoming a whatever are so, in many cases, like, actively block people with disabilities. That could be stuff around testing, where there's not accessible enough testing, a part of tests for medical school. That could be stuff around like really simple stuff like examining tables, not being able to move up and down, like very, very basic like engineering, universal design sort of stuff. But one thing I would love to happen is, in addition to curricular changes, where some of the stuff that I'm saying and some of the stuff that people in disability space have been saying for a long time, and how thinking about disability more capaciously actually gives clinicians tools simply to improve health outcomes and improve quality and equity of care. In addition to the curricular stuff, there's also just basic access changes that need to be addressed at the level of getting into med school, being in med school, staying in med school, residency, like all of that. We can do it, but it's going to take a massive amount of work and kind of rethinking, and it will require much more serious listening to people with disabilities about what needs to be changed so that they can be included on both sides of the medical encounter. Beautiful, thank you.
Thank you. I'd like to ask a question with my GP hat on. I really liked your last recommendations, the three part there. And I'm thinking it would be great if we could apply that more into our GP interactions. And at the same time, it makes me feel a bit like the picture you had, the person in the wheelchair looking at the stairs, thinking of the system that I feel I'm battling every day, because you have the 15-minute appointment, and you need to sort of see that many patients a day, which is not great if you want to apply those principles.
Absolutely.
So I'm wondering, have you thought about structural changes in this sense, and the healthcare system really having that structural ableism built into it? And how can we make changes to that system that make it sort of that take away at least some of that barrier of applying those principles that you've presented there?
Thank you so much for that question, and it's such an important point. Whenever I'm talking in med schools, I always want to have like a caveat of like, all of you who are actually in medicine have to do too much, have to learn too much, and you don't have enough time for like anything. I think it's absolutely, it's kind of ridiculous, the point that we've gotten to. My answer will be, I don't know the funding situation in New Zealand, so I'm going to focus on the US, forgive me, but in a US context, the absolute first step is we have to get profit out of medicine. The fact that we have a more or less, at the end of the day, for-profit system is getting in the way of, for example, structural changes where you have more than 15 minutes with the patient. And there's all sorts of evidence that, of course, when you do have more than 15 minutes, it improves health outcomes. Like, what do you know? It's not data that the system is broken that is getting in the way of it changing. It's the forces that be worrying about their bottom line. That's in the US context. I should add here, this is very important, that this is not just about profit-driven motivations at the level of the healthcare system. There is an equally, if not more important conversation to be had about the insurance industry, which is just is metastasizing, continuously metastasizing healthcare systems in ways that typically do not end in actual better health outcomes for patients. Aside from those, so there's the kind of large stuff, but yeah, the data suggests we need to be able to, as GPs need to be able to spend more time with each individual patient. They need to have less on their plate so that they can spend more time with each patient. They need continual medical education needs to be easier to access, needs to be, like, there's so much stuff structurally that needs to be done. And I don't have all the answers, but there's just like a couple of initial thoughts.